Good afternoon. Before we actually start the lecture part, I mean, certainly Dr. Crum is someone who doesn't need an introduction, certainly to this audience that's enriched for gynecologists. But just wanted to say a few words about him as an opportunity to say thank you to him, really. So I was kind of telling him that he's not huge on Lord of the Rings, but during my whole fellowship year at the Brigham, I felt a little bit like a hobbit on my quest with Gandalf. And there's something about him that that just attracts you to wanting to work with him, wanting to be around him, wanting to just learn as much as you can from him. And I don't quite know what it is exactly, but it's almost magical. And the one thing I can say about him is that he's certainly someone who I simply just want to emulate. And I don't say that about really not too many people about that. And maybe one day, I'll be able to emulate some of the characters that he's able to put forward, and really, and it really pushes you to be like him. He's an excellent mentor, teacher, pathologist, researcher, and just a great human being to be around. His illustrious career doesn't need to be highlighted. Maybe a few highlights is that he was at University of Virginia originally for medical school and path training, and then fellowship training in gynepath in Columbia. He did spend a few years as a staff in University of Virginia, but Brigham is where it's been for the last number of years, during which his all his research work took place, and of course as well as being a past president of USCAP among just other things, and was the division head for the women's and perinatal pathology during that time. So really thank you to Dr. Crum for coming to Toronto. And I was a little saddened to hear that this is going to be his sort of last talk, sort of his last academic talk. So thank you for making our humble event your last stop. A little sad to hear it, but very grateful. So without further ado, thank you.
I'd like to begin by thanking Dr. Stroker and Ju-Yoon for the invitation. I've been very lucky to have had wonderful fellows through the years, several of which are here, and who have been really enriched our own experience at the Brigham. When I think about mentors, just before I start, I had an organic professor that really got me into medical school, probably because my grades weren't going to get me there. And I went back to see him years later when he was, I think, in his late 80s, and he was a very famous medicinal chemist. And I saw him, and I kind of got choked up and told him how much I really appreciated all the things he did for me. And his response was, "You were so pitiful, somebody had to help you." That's exactly, that's what he said. So I won't say that to Ju-Yoon because he's obviously not pitiful, but that's how he looked at us. We're children to them, and they help us along even when you think maybe they shouldn't have. One other correction: there's a picture of me that they did project up there that is not me, actually. It's some kind of it was some kind of Photoshop rendition of me by somebody at the Brigham when they were taking pictures, who never cleared it with me, and then that's what turned up. So if I don't look like that, it's not my fault. I'm never going to be able to get my hands on the person who did it. So today we're going to talk about, in the next few minutes, about high-grade serous cancer and closing the loop. And what I mean is basically trying to sort of get around the entire concept, and so that we can kind of figure it out. And just to begin with, no disclosures. These are a couple of things I always bring up. The Marcus Aurelius statement, which is everything we hear is opinion, not a fact. It's perspective, not truth. So whenever you have a person speaking, they're usually, telling you what they think is correct. And obviously, they usually have to be the hero of their own life story when they give this talk, as you might expect from all the talks we've listened to through the years. And everybody does come from their own perspective. When you look at research, research is driven a couple of different ways. One is by hypothesis driven, which I always thought was the really way to do it, to posed the hypothesis, asked the question. The only difficulty is usually you had to come up with a technique to answer the question, which made it difficult, but could be very rewarding. And now we're more data-driven. We've got tremendous amounts of data coming out, and it's easy to belittle that and say, well, they're just waiting for the data to come out or they can create something. But that also gives you the opportunity to really find new things and to go forward. So I think we're really looking at both of them. And I think all of our accomplishments are really determined by both approaches, things that come into our lab that we can look at. As far as closing the loop, when you look at cervical adenocarcinoma, for example, if you looked at an adenocarcinoma of the cervix back around 1980, you'd sit there and say, is it endometrioid? Does she have both a cancer of the uterus and the cervix? And once you knew HPV was the factor, it cleared it all up to a large degree, and that you knew that really cancers in different sites were totally different because of their etiology. Then, of course, non-HPV gastric type pathway came up in recent years, which has helped us to close the loop somewhat. And for example, an adenocarcinoma of the cervix. When you look at vulvar squamous cancer, back in the old days, it really wasn't very clear until HPV came along. And then, of course, P53 came along, and then PIK3CA came along, and we began to close the loop, at least on some of the squamous lesions we see in vulvar cancer. So that's what I mean by closing the loop. When you look at extra-uterine high-grade serous cancer, it's more complicated because it occurs in several different sites. And so the real loop closing is just trying to figure out where they're coming from and why they look the way they do. And why do we get this disparity? So we'll talk a bit about what we knew, what we've learned, what we thought, some unsolved mysteries, talk about maybe lumping or splitting in the meantime. So just a couple of quick background, pieces of information. With ovarian cancer, it's it afflicts about 22,000 women a year in this country, and it is a major cause of death. It's a cause of death in a significant percentage of those individuals. And most of the improvements in survival over the years have been more aggressive, surgical cytoreduction, the advent of certain chemotherapeutic agents, and just better supportive care. But in the end, the 10-year survival is still maybe about 20% or less. And when you look at the improvements in survival, a lot of them have been more in the intermediate term of just shifting the curve over, with chemotherapy. So instead of most of them dying in 2.5 years, half of them were dying maybe in 5 years. And that was because you were pushing the curve. But when you look at the end of the curve, it's pretty clear that no matter whether you're BRCA mutated or not, roughly you settle down around 20% survival at 10 years. Interesting thing about long-term survivals in ovarian cancer, or at least high-grade serous cancer, is most of them are high stage when they're diagnosed, as you know. And a lot of them recur, a lot of them are suboptimally reduced, and some of them have short platinum-free intervals. But in general, they usually had a high mutational burden, as you might expect. The BRCA population tends to do a little better. Tumor-infiltrating lymphocytes or host response influenced some length of survival, but it had nothing to do with stage for that matter. So that's why it's a kind of a mysterious disease to deal with. And if you take out the tubes and ovaries in a BRCA population, you reduce the risk of dying of that cancer by 85 or 90%. So that's sort of where we are, at this point coming forward. In terms of the historic origins of high-grade serous cancer, we all knew there were sort of three things. Number one is the most common was the ovarian surface or its inclusions, which theoretically were the source of the cancer. Every now and then you would get a tumor in the endosalpinx, which would stretch the fallopian tube, and therefore one could say that's definitely a tubal cancer. So most of our tubal cancers were the sausage cancers that we saw in the tube that we could say, yes, we know that started there. And then you had the primary peritoneal cancers where you had some involvement of serosal surfaces, but no involvement of either the tube or the ovary. And those are the three categories that we basically dealt with. And if you look at this image in the lower image here, the real anchor for ovarian cancer was in the ovary. That's where it was anchored. And I talk a lot about anchors because you need an anchor to start. You got to find someplace where you're sure. And so at that point, people were sure they thought that they started in the ovary. Well, one person worth mentioning is J.D. Woodruff. He was the chief at Hopkins back before Bob Kerman took the job in the 1990s. And even back in the 1970s, Woodruff was pretty aware of the fact that ovarian cancer, this particularly high-grade serous cancer, was a mystery, and that the only way we were going to make any inroads was to try to figure out how it developed. And he had a massive ego. I liked him, but he was very dogmatic, and he sometimes looked at ovarian cancer sometimes as a mesothelial type disease. He said this is sort of like an intraperitoneal disease, something no one else really thought about. But he was really paying attention to the fact that it was very hard to pinpoint the source. The fallopian tube model started coming up about 23 years ago, just after Mary Claire King and her colleagues, discovered, the BRCA tumor suppressor genes, and that led to frequent risk reduction salpingo-oophorectomies in women who are susceptible. And probably one of the more important papers was by Zwiemer et al. Around 2000, where they actually isolate a couple of early cancers in the tube and match them up with the tumor that was by mutation, that the tumors were in the peritoneal cavity. And a number of other individuals began to discover occasional cancers in the fallopian tube. And so people began to appreciate at least that the tube could be a player, but they didn't really know to what extent. I remember Terry Colgan was giving a presentation years ago at the USCAP meeting. I came off the plane, walked into the ISJIB meeting and opened my mouth, which was not one of my brighter moments, because he was up there and I got up and said, I never see these things in the fallopian tube. Because I was thinking about tubal ligations, but you never see a cancer in a tubal ligation. And Terry said, well, we're finding some cases in the fallopian tube. I talked to him later about it and apologized for being ridiculous. And he was very nice. And it was an interesting concept. So the loop on the origins of cancer began to close a little bit because people started looking at the fallopian tube. And this loop is, we're trying to close the loop on really how do these tumors develop. Well, a couple of years later, I was writing my first book, and we were going to have a chapter on the fallopian tube and broad ligament, but nobody wants to write that chapter, right? In 2004, no one cared about the fallopian tube. So I had to write the chapter. And so I decided I had to find something interesting to talk about. So I went back and looked up some comments about the fallopian tube, and one of Zwiemer's colleagues, Jürgen Peek, had written a couple of papers on it, and he had a little review where he said, I think these tumors could come from the tube, and he cited a lot of animal data. And so I said, okay, well, I'll just go ahead and do something. So I decided to create this protocol. It's called the CPIN protocol. I said, that's what we'll do. We'll go ahead and section the tubes, and because if we're going to find it, we better look at the whole tube. So we had cross sections of the central tube, and then we did sagittal sections of the distal tube, and that was in order to make sure we saw the whole tube. And we started this in January of 2005. And what happened was in about a month, we had 5 cases. These are in brackets. And so we wrote that first group up with Fabiola Medeiros, with a comment that these tumors are probably, a lot of tumors in the BRCA population were coming from the distal fallopian tube. And so this kind of caught on, and a lot of other institutions began to use it. And recently, actually got its own Wikipedia page, and which may not be a good thing, but anyway, it's brief. You won't hear my name mentioned, because if I mention my name in it, they wouldn't accept it. So we just described some of the papers that supported it, and it's become kind of the standard of approach to the fallopian tube in patients who are BRCA or with serous cancer. And so this shifts the perception of the origins of high-grade serous cancer. And it had a lot to do, when you think about what drives the equation is when you can find a specific place where it starts. And I'll get to that in a moment. But in this case, you can see, you might have a small cancer in the distal tube. Here's a case where you might have a surface lesion actually in the ovary. Then when we put the tube through, we managed to, after several sections, to find an early cancer. And so that sort of began to take tubo-ovarian cancers, if you will, into that category. And then when you start thinking about ovarian surface or ovarian surface malignancies with ovarian involvement, you began to think, well, maybe the tube's involved with that as well. But then again, you also had your primary peritoneals, which were really a different animal. So we began to sort of separate these out a little bit. And when you talk about the distal model, you know, we had Fabiola's paper and then a number of papers. Cass also wrote a paper around the same time. They're in their group of looking at the distal tube. But what it did was it shifted the emphasis from the ovary over to the fallopian tube. And that's kind of a critical thing. And that began to close the loop a little bit on where these cancers come from. And this is where you might say, well, do you lump or do you split? And well, obviously, when you start pointing to the fallopian tube, you're starting to split a little bit. And I had an oncologist who said, well, it doesn't really matter where the tumor begins. We treat them all the same anyway. And so, you know, and that's maybe true, but knowing exactly where the tumor comes from may make a difference. One of our reviewers of our earlier papers says it doesn't make any sense that ovarian cancer can start in the fallopian tube. So you're sitting there looking through the microscope and saying, you know, this is pretty interesting. And you got a reviewer saying, no, it's dumb. You know, so it was kind of crazy. But location kind of changes the narrative. And I think it's important because I didn't expect it. You know, I just said, let's look in the distal tube. But the minute you can localize a tumor to one area, then you can ask a lot of other questions. You know, if you're saying, well, they have them in both the tube and the ovary, nobody's going to sit there and say, well, we should just take all the tubes out because they'd still think the ovary is a site, right? Or if you said they can occur in either site, then they may not ask other questions as well as to where's the precursor. Once you are focusing on the distal fallopian tube, then you know you can ask some additional questions. And so the next question you're asked, what about cancers in general? If they have high-grade serous cancers, but they're not BRCA. And so we started looking, and we found that many cases did have something in the fallopian tube that looked like a source. And that was the next paper. And it's interesting, though, that other people did apply it, and you had everybody from 10 to 60% of symptomatic high-grade serous cancers had a stick, if you will, a serous tubal intraepithelial carcinoma in the fallopian tube. And of course, the ones that were 10%, we figured weren't looking very carefully, but there was this range, and we didn't really ask a lot of questions at the time. And then there was this notion about serous precursors to the fallopian tube. And I didn't think about that at all until when we were staining a lot of fallopian tubes because you're nervous you're going to miss something. And then you suddenly start, looking at a fallopian tube that really has rather unimpressive epithelium and discovering that it's intensely p53 positive. And that kind of automatically, a little bell goes off and says, well, these are probably related. And it's interesting, they occur in the same place the cancers start. And so it begins to give you a kind of a model where you can come up with an idea that maybe these tumors start. And a lot of people have things that are never going to do anything. These are patients that are not BRCA. Yet 50% of women have these in their fallopian tubes. The great majority are never going to have any issues because these are earlier lesions. But it's a lot like mild dysplasia. It's a lot like a lot of things that you get in different areas of the body where you may have some genetic abnormality that's never going to progress to becoming something serious. And what this produced were these progression models. And as Ju Yun alluded to, with the Vogelstein model, everybody loves the progression model. So the minute you start finding these early lesions in patients who are at risk genetically, the fact that you found them, you can automatically kind of conjure up a progression model where you go from, let's say, a p53 mutation to a proliferation, a stick, so-called intraepithelial carcinoma, and then you develop cancer. And there's no lack of models out there, many of which are ours and others. And here's a more recent one where they even add a lot of genes and kind of give you a Vogelstein approach with a lot of different, and it all looks good. And the question is, was it really valid? And I think it's at this point, you should ask the question I should have asked a long time ago, which is when you're looking at patients who are asymptomatic and you're finding stuff, it's different from when you find patients who have cancer. It's the same thing when you look at, EIN or early lesions of the endometrium. I remember Leopold Koss once did a study where he had some sort of thing called a mymark. It was a little screw you put in the uterus and turned it around, and it collected endometrial lining. And he found actually when he did that, almost as many cancers as he found precursors, which doesn't make any sense because precursors should be much more common. So sometimes you don't really understand the precursor cancer continuum, and this led people to think that yes, there must be something like that. So the question is, do you lump or do you split in terms of the origins of ovarian cancer? Is it all just a stick that goes bad, or is there some other mechanism that might explain the pathways to cancer? Well, Brown and Palmer, smart people, got together and produced, based upon the data available about 10 or 12 years ago, this model where they had, you start off with genotoxic injury, in the tube, then you got a stick, and then you got an early cancer, and then you got clinical detected, and it became advanced with a time course of 5.1 years. And that was very theoretical, and everybody loved that. The problem was, the first thing we decided, we saw that, we figured, well, since all we find are these sticks in women who have BRCA mutations. So, example, if you bring an asymptomatic BRCA mutation patient in, you've got about maybe a 1 to 5% chance that you might find an early cancer precursor. This is an asymptomatic BRCA patient. It's very unlikely that you'll find anything beyond the tube. It may be in the tube, it may be tube, and maybe a little bit beyond if it's very early. And so you figure that when you look at the symptomatic women who have BRCA mutations, you'd find the same frequency of early precursors, but they didn't. It turned out only about a third of women who have advanced disease, who have a BRCA mutation, can you actually find that little, smoking gun in the fallopian tube. And you could argue, well, it just got overgrown, or it wasn't. You could argue a lot of things, but it just wasn't findable. And that was the same as you found in the general population. And so when you look at this, it was sort of like the iceberg effect. We were looking at something that was obvious. The question was that part that was underwater the same thing, or was there some other type of mechanism for developing cancer, high-grade serous carcinoma, that didn't necessarily involve this typical precursor continuum? So we did a couple of studies. One we did with the BRCA group again with Brooke Howitt, where we postulated that there might be an alternate precursor, because it was an alternate precursor. Was it a stick that got overgrown rapidly? Was there a shorter occult period? Was there some non-classic pathology that was involved? The non-classic pathology I'll get to in a minute, but at this point, it's kind of convenient to break high-grade serous cancer down into 3 different groups. And this is based upon, for me, just a simple review of path reports. And we did the CPM protocol on what was found. And in our path reports, last couple of years, actually in only a little less than 20%, we actually found a stick that was reported in the path report. I guess if you looked harder on the cases, you might find more. On the other end, you had things that were called primary peritoneal, where about 20% did not have anything in the tubes of the ovaries to speak of, mainly on the surface only. Therefore, they probably started outside that area. But in the middle, you had the bulk of the cancers of high-grade serous cancer, as you know, where you find a rather substantial amount of ovarian and tubal involvement. You don't find a stick, but you assume it probably started in that region. It's just unclear as to exactly what's going on. So why the low frequency of stick? Is it because the tumor can develop in the ovary? Are there variants of high-grade cancer that just have a lower frequency of stick? Do high-grade serous cancers start other places from tubal cells? Do you get precursor escape where cells just leave the tubing and go bad later? Are there unique and rapidly evolving pathways of high-grade serous cancer? Well, the support for the ovarian surface epithelium's cortical inclusion cyst theory came from a number of studies where they basically were able to find some genetic changes in the ovarian surface epithelium the problem was they weren't finding a whole lot more at that time. For example, in this left period thing, if you stain the ovarian surface epithelium or cortical inclusion cyst with calretin and FOXJ1, which are markers for mesothelium and for mullerian epithelium, there's often an overlap, suggesting maybe there is an unusual type of epithelium in the ovary that could produce an ovarian cancer that's maybe related in some way to mesothelium. But that was impossible to prove. What we found was when you started looking for p53 positive epithelium in the ovarian surface, you just couldn't find it. Two very large studies were looking at ovarian cortical inclusion cysts, looking for those telltale p53 mutations that you could say could have been where the tumors originated in the ovary, but they weren't found. And that was one piece of data that didn't support the ovary as a source. It's interesting about different morphologies, and I know Jelena Merkovic was talking a lot about mesonephric-like carcinomas, where subtle differences in morphology could make a big difference in terms of biology. And there's a little history of that in the actual ovary, and it began actually with Elvia Silva, who is a somewhat cantankerous good friend, colleague of mine from the Anderson, who back in the 90s said, well, these cancers that have a transitional look in the ovary have a better outcome. And he called them transitional, really transitional variants of serous carcinoma. But he couldn't get anybody to buy into that, and the WHO would not classify it as a distinct entity. But he put it out there. And then we came along with Michael Rowe a few years later, and we decided to divide high-grade serous cancers into those that looked a little endometrioid, those that looked kind of in between, and those that looked like classic high-grade serous. And it turned out the ones that looked endometrioid had a lower frequency of stick for some reason, a lower frequency of a tubal primary source that we could identify. When we wrote that, we had to endure a certain amount of criticism because there was a letter to the editor, which I occasionally show, Modern Pathology, criticizing us, saying, we were trying to divide high-grade serous into 3 categories, which was going to confuse pathologists. They'd be confused. We had to call them all high-grade serous. I'm not going to tell you who pushed that, but it came in as a letter to the editor. Our response was, well, you really should separate them to try to understand them. And the mesonephric-like argument would be one that it's a reason why you try to separate things. They look different. Try to figure out why. And a year later, Rob Soslow, actually at Sloan Kettering, sort of took that one step further with the so-called SET tumors. They were solid endometrioid-like or transitional. They were subsets of high-grade serous cancer, which actually were quite unique. We found they had a lower frequency of a precursor in the tube, and he also found that they had a stronger association with BRCA mutations. And then Brooke and Lauren Rittenhouse published papers suggesting they had a lower frequency of STIC, but also mutations in homologous recombination genes and chemoresponsiveness. So that was nice. It should show that there are different subsets of high-grade serous. They may have a lower frequency of a precursor, but we still didn't know, really, it didn't really answer anything. We were still sitting there, trying to figure out what was the difference between these categories in terms of where they may be coming from. So the next group we decided to look at, having not done terribly well, there was just the primary peritoneal group. So cancers that were suddenly arising in the peritoneal cavity, how did that happen? How do you explain that? Because one theory is they come from endosalpingiosis, little embryonic rests of mullerian epithelium in the peritoneum or some other source. So we decided to look at this. And in the extra-ovarian model of high-grade serous cancer, there's 2 or 3 different ways in which this can happen. Either you could have undiagnosed cancer come out of the tube and spread to the peritoneum and grow into a cancer. You could have an earlier tubal lesion that's not really malignant that could shed into the peritoneal cavity and become malignant later. Or you could simply have endosalpingiosis in the peritoneal cavity. Those are different things that could explain a tumor arising away from the tubes and ovaries. We focused on these early serous proliferations of the fimbria, which are basically these early precursors which we call P53 signatures if they were bland, so-called stills or intraepithelial lesions if they weren't quite sticks, and sticks if they obviously were malignant. And we decided to examine that in a study where we actually took a series of women who had no evidence of tubal involvement, serially sectioned the fallopian tubes, found evidence of early serous proliferations, and then analyzed them for P53 sequence and compared them to the cancers. And Rinda soon did this, and this was, I think we probably have still boxes stacked up in the lab with all the sections, after Rinda did the study. And what she found was, yes, there was a small number of these ESPs, if you will, that did turn up in these cases. And in some of the cases, we were able to find credible evidence that they contained a mutation that matched the cancer in the peritoneal cavity, suggesting that that early change in the fallopian tube, which was not a malignancy yet, could be related to what was happening in the peritoneum. And that sort of came up with the so-called idea of precursor escape, where cells could escape from the fallopian tube. Now, you might say, well, that needs more data, and you're absolutely correct. But certainly with the serous tubal intraepithelial carcinomas, it's already proven. A woman who's got a stick comes back 10 years later with a disseminated peritoneal cancer that matches the stick. And they may take a long time to come back. And that's worth mentioning because what it means is that when somebody makes a diagnosis of serous tubal intraepithelial carcinoma in an asymptomatic patient, they're diagnosing something that may not truly be a malignancy yet, but is maybe on the way, or it's halfway. And so you have to wait several years for it to become a malignancy in the peritoneum because the cells have to shed and then undergo additional genetic changes. So it's not an instantaneous metastasizing malignancy. That would explain this concept where the cells escape and then they may become malignant later. And here's just an example where a patient's got a tiny tumor in her ovarian cortex. And then when you look in the fallopian tube, you have extensive P53 positive epithelium, which doesn't really qualify for malignancy, but is a potential source of the cells that then turned up on the ovarian cortex as a metastatic malignancy. And in parallel with these studies was a couple other studies, which I think was kind of interesting, was these sort of phylogenetic trees that they make, where they basically take sequencing data and try to construct a timeline, from the very beginning of the mutation to the cancer. In other words, and you try to link all these different entities to the cancer, but you can see they're rather branching, meaning that it's very difficult to produce the Vogelgram in the fallopian tube. In other words, it's hard to find this, then this, and this, and link them all linearly. Often you'll find several different entities. And in some of the studies that Yiming Shi did, they actually found that the cancer actually was more closely related to a lesser change in the tube than the more advanced change. And that again raises questions that we don't really understand about that nonlinearity. We had a case example in our own studies where we had bilateral precursors in the tube. One was not really quite a stick, the other was a stick. Both had the same mutation as the cancer. And one of them has to be the primary. And we couldn't really figure that out. And actually, Herman Chui is also from the same group and works at Memorial, did really similar work trying to link low-grade serous to high-grade serous. And again, came up with these non-linear things where they took different entities, different precursors, and not all of them were related to the cancer, and sometimes not the ones that you expected to were not directly related. It just speaks to the complexity of how cancers develop in the female genital tract. So we had these two concepts. One is precursor escape, another is a stick that becomes malignant. So what do you do about all these extensive tubovarian high-grade serous cancers that don't have a stick? Is it a fast trajectory? Is it going from 0 to 60? And that was always sort of what I thought was probably happening, because you don't find a stick. And it's easy to say, well, they had a long-standing stick that got grown over by the cancer. That's hard to believe. That's hard to really accept as a likely scenario either. So, and one good example of that is, here's an example of a large tumor in the fallopian tube. And if you look at the stain for P53, there's a little stretch of epithelium next to it that also contains the P53 mutation, but it's morphologically almost normal. So you go from having normal epithelium to a bulky tumor, meaning that some kind of transition occurred that you can't identify morphologically. You don't really have the early cancer. You went from 0 to 60. And I think that's not uncommon to run into in the fallopian tube. So how does that happen? Well, one of the possibilities is so-called catastrophic genomic events. So when Ju Yun came to visit, I forget what year it was. It's been forever. No, 2017, 2016, 18.
Observation.
When you came to, no, when you came on, when you started your fellowship. 2020? Okay. Seems like, well, no, I say this because he came to visit before, years before, and I always sort of link that all together linearly. And then he came back when he took the fellowship. So Ju Yun says, well, what about, chromothripsis? And then my response was, chromo what? What are you talking about? But it was the concept of catastrophic, and he said, what about catastrophic genomic events? There's something going on, in other systems. And what these really amount to, in my own simplistic reasoning, is these are things that happen that probably have to happen over a short period of time, because they're not like sequential mutations. They're structural events that occur in the genome that you don't gradually develop. In other words, you don't get genome doubling over numerous events. It probably doubles over some kind of unusual mitotic event or some other lack of regulation in the mitosis. And there's chromothripsis, which is not the same. It's totally different, but has been linked or preceded by genome doubling in a number of experimental systems. Chromothripsis being something where you get clustered chromosomal genomic rearrangements. Notice enough of the chromosome is altered at once to suggest that it wasn't sequential. It happened all at once. In other words, you have, and then there are different ways of measuring it, but it's enough linked areas that change all at once to suggest that something significant happened in one hit. And what these would mean is that you could go from 0 to 60 in terms of developing a neoplasm or malignancy without going through numerous step-by-step events. And this has been sort of mapped out in a review that was by Coleman et al., again, suggesting there's several scenarios. There could be, stepwise mutations or stepwise genomic changes, or you just simply have polyploidy, or in this case, you could have chromothripsis occur in a single mutation, and then you go from having normal tissue to something that's it could even be malignant or more advanced. And so we decided to look at this, and so this took a while to get this done. We ended up getting together about 26 cases of high-grade serous cancer, and I subdivided them into two different groups. One group was tube or ovary, the tubo-ovarian axis, if you will. It was just the tube or tube and ovary, because you figure they're kind of linked. And the other was primary peritoneal, the ones that didn't involve either the tube or the ovary. And they were analyzed using an OncoScan array at the Brigham, which looks at a lot of different SNPs, and a minimum of 10 continuous segments had to be altered together to be diagnosed as chromothripsis. So this is just sort of not artificial, but it's a consistent way of identifying this. And the presence or absence of some kind of catastrophic genomic change, be it either polyploid or chromothripsis, was then determined by our colleague Ezra Ligon in cytogenetics. And the overall frequency of these catastrophic events was about 56%. Now, this is actually 2% off. So a little over half of these cancers had it. But what was interesting was there was a fairly strong association between tumor distribution and chromothripsis. For example, if you had a tubo-ovarian cancer, it was as high as almost 70-some%. If it was only the primary peritoneal group, it was much less. It was like 20%. It was also strongly associated with ovarian involvement. Just about every case that had any parenchymal ovarian involvement had chromothripsis or polyploidy. The primary peritoneal group was much less. So it creates a scenario where you can begin to actually divide these cases out. There were cases of very early tumors of the tube that did not have chromothripsis. The more advanced cases did. And you could ask a lot of questions about that. But what it tells us is that when you take a look at this group, these three different groups of tumors, when patients have a stick, there's a variable trajectory. They may have a stick that slowly develops or a stick that just, let's say, then extensively spreads to the ovary, and therefore the frequency of catastrophic events is more variable. On the other hand, if you go to the primary peritoneal group, it's very low. And then when you go to the group that, that has obviously more extensive involvement of the ovaries and tubes, it's very high. And so what that does, that's one of the very first observations probably made where chromothripsis in a tumor group could be separated according to tumor pattern. It is claimed that chromothripsis or polyploidy can portend a worse prognosis, but no one's ever actually looked at a tumor group like high-grade serous cancer where you actually have 2 or 3 different presentations that suggest different origins, or at least different sites where the tumor developed. In this case, there seems to be a correlation between these catastrophic events and these tumors. Now, when a patient has this widespread involvement of the fallopian tube and the ovary as a mass, you could argue, well, maybe it started as an ovarian cancer. You could argue that. It's hard to prove. You could also argue that maybe it didn't develop chromothripsis or polyploidy until it got in the ovary. Or you could argue that it just developed rapidly. This event occurred early in the fallopian tube. The tumor did not sit there as a precursor for long-standing and just evolved into a malignancy, which I think is more likely, that then rapidly involved the adjacent ovary. And I think that would explain why we see many of these patients coming in with extensive involvement. It isn't just a tumor that develops and overgrows the stick. It's really something unusual that initiates the cancer that is not a long, gradual process. So with this, we felt like it begins to close the loop if you use this as your argument for explaining why you're seeing what you're seeing. And so I think the important thing is that risk reduction surgery enriches for the discovery of lesions that you're going to probably diagnose as either intraepithelial or limited, because you're looking at an asymptomatic patient who's got something that's not moving fast, right? And at the time of the discovery, they've not yet possessed the complement of genetic changes to metastasize. But what risk reduction surgery kind of took us away from thinking about was the more common pathway to high-grade cancer, which is probably a rapidly developing malignancy. And we all, if you work with clinicians a lot who deal with women at risk, they'll have a 38-year-old, a 39-year-old woman with a BRCA1 mutation who wants to wait a little bit longer before they have their risk reduction surgery. And 6 months later, they've got tumor, and I think everybody understands this. So when you think about preventing cancer, I think you can prevent an awful lot of these cancers by removing the fallopian tubes. But if you leave them in too long, you may then obviously be faced with the worst scenario. And so when it's a dualistic pathway to cancer that's really been courtesy of risk reduction salpingo operectomy. All these asymptomatic women with early disease helped create this gradual timeline from stick to cancer. When what was really happening was when they were coming in symptomatic, you were looking at a different animal, a different phenomenon, which was probably a tumor that was accelerating from 0 to 60 due to these catastrophic events or in relation to the catastrophic events. What about the ovary? Well, LVO's always been on my case about the fallopian tube, and so he still pushes the ovary as a possibility. And I can't deny him that. It's just very difficult to find a credible precursor. But he and Jinsong Liu have been looking at this, and Jinsong Liu actually looked a lot at polyploidy back several years ago. He was one of the first people to actually think of polyploidy as being an important aspect of early ovarian carcinogenesis. So they suggested, well, maybe that could be happening. And that's what they think. What most everybody else says is they think that the ovarian involvement is just an acceleration of the tumor that's coming off the fallopian tube. But anyway, that's one thing they think might be real. When you look at risks following salpingectomy, if you have an opportunistic salpingectomy based on the recent British Columbia data, they show that the frequency of opportunistic salpingectomy has gone up significantly in their part of the world, and it's been increasingly used for sterilizations. In terms of outcomes, it's really rather preliminary data because there's not a lot of follow-up. But what they're finding is that women who have opportunistic salpingectomy have extremely low risk of coming up with high-grade serous carcinoma. They may get other ovarian cancers, but they're not as many, and that's based upon their comparison of women who've had it versus those who did not. One of my family members says, "Well, I need birth control. What do I do?" I say, "Well, you might want to talk to them about opportunistic salpingectomy." And they say, "I don't know about that." I said, "Well, talk to your physician anyway." I would. I think it's a little early, but it's impressive. It doesn't mean it's going to prevent all ovarian cancers, but it looks interesting. The risk reduction salpingectomy in women who are BRCA, as opposed to women who are just non-BRCA, has found that an increasing risk of peritoneal cancer over time if they have a stick. And they found that when they take them out to 10 years, the risk of coming back with peritoneal cancer is as high as 27%. This has been challenged by people who think this may be an overestimation. But what it emphasizes is that, two things, I think. One, if you get opportunistic salpingectomy, you probably significantly reduce the risk of cancer. But if you find a stick in a salpingectomy, there is a risk of recurrence. And that raises another question going forward historically, is how to prevent those cancers from happening. You can probably prevent a lot of cancers from happening by taking out the fallopian tubes, when it becomes appropriate to do so in the general population. But what do you do if you find a stick? So preventing extrauterine cancer, I think the intrauterine cancer, the premise would be you can prevent a lot of tubal ovarian cancers by opportunistic salpingectomy. What you're dealing with, though, you're dealing with this other group, which we'll get to. And that group is more difficult because they are shedding cells at the time of your salpingectomy. Scenario one is you remove the fallopian tubes before anything's happened, and the risk is extremely low of ever developing cancer. If you remove the fallopian tubes after they've developed a significant precursor, you may still have a rather low frequency of recurrence, but it could be high enough to worry about because cells may be shed into the peritoneal cavity that could later become malignant. And so this raises another theoretical, when you go forward, is there some way to prevent cancer from recurring in a woman who may have shed cells into her peritoneal cavity? And the reason I think it's important is because a lot of patients who do have significant early lesions of the tube, when they develop their cancers many years down the road, suggesting that the cells may be out in the peritoneal cavity, and maybe only one of them then goes the next step to become malignant. If that's the case, then you may have cells at that point floating around the cavity, only one of which may be destined to become the malignant cell. And so the question is, can you prevent cancer by better peritoneal washing or by some other maneuver which would neutralize those cells? And I think this is what's being discussed now as they try to sort of digest all this data about the risk of developing cancer after you find an early cancer in the fallopian tube in a BRCA patient or anybody else. But it's just not yet been solved. But I would say that the next area that's worth doing research on is understanding what's happening in the peritoneal milieu of patients, both to understand primary peritoneal carcinoma as well as to understand how to intercept these scattered cells that may be floating in the peritoneum after one of these risk reduction surgeries that would place the patients at risk. So future research, I think there's a lot of things people could do. I think understanding really what's happening in the peritoneal cavity, carefully examining it for epithelial cells and these risk reduction surgeries. looking at strategies to remove cells from the peritoneal cavity safely. Because once you remove the fallopian tubes, there's no other cells to escape into the peritoneal cavity. Imaging studies or even molecular profiling. So I'll finish with some perspectives for the trainees. If you do find something interesting, write about it, and if it's important, stay on it. A lot of times people write one paper and say, "Well, they'll send me the Nobel Prize in 10 years." I tell them, I say, always write about it and keep pursuing it and try to understand it. And you're not going to win any prizes, but you should keep doing that because people will forget about it. I tell that no one cares about what you did 20 years ago. So don't come tell me how great the paper was 20 years ago. I've heard that just tell me, because nobody cares anymore. People have very short attention span. I always tell the story. I'm sitting in the train, the subway in Boston. There's a couple of kids sitting there. One's listening to music, and the other guy says, "What are you listening to?" He says, "Fleetwood Mac." And he says, "Never heard of it." So, and the other story is there's that story. There was that song by Sting, "Shape of My Heart." So Sting writes "Shape of My Heart," a very popular song. So I go on the internet and I see Sting singing, and he's got like 60 million hits. And I tell my grandson, I said, "Look, that's a great song." And he hears it. He goes on his iPhone and says, and he pulls up this one by Juice WRLD, who's a rap artist who's singing over "Shape of My Heart." He says he's got a 1.5 billion hits, granddad. So things move fast, and it doesn't matter what you do back then. Your epiphany is never perfect. Keep looking. Let somebody else lump. Always split. Don't combine things until you're absolutely sure. And we're all guilty of being lumpers when we're looking at stuff we're not interested in. Don't spend valuable time in a pissing contest, particularly in a consensus conference where the outcome is preordained. That's a little cynical, but anyway, do it for yourself and make sure you get what you can. When you finish your career, whatever you're doing, make sure you did what you wanted to do and didn't get talked into doing not too much, talked into something you didn't do, because we're all being talked into stuff. Just acknowledgments to everybody who participated in these studies over the years. And thank you very much for your attention.
Thank you very much for that full presentation. Opening with a question from the chat. The CFIM protocol involves embedding the whole tube. How many HC sections are you supposed to examine, and does IHC have a role? Thank you.
Yeah, I think in general, we just embed one section of each. We don't do levels. I think if you find something unusual, you might take additional levels. We don't stain them. We just look at them, try to look at them fairly carefully. I think if there's something unusual, you'll find it. If you go through really quickly, you might miss something, but I think if you take a little bit of time, if there's something important, you'll see it. Then I think what I would do then is maybe just do some no-waste sections and stain it with p53 and maybe MIB, just to see if it's proliferative. But you'll be generally going on the histology.
Actually, on the histology, what is your cutoff for stick versus still?
Well, I'll get into this at the case presentation, but in general, what we used to really focus on was polarity preserved. Although you'll see some loss of polarity in the fallopian tube epithelium, where you get two different cell populations next to each other, ciliated and secretory. But polarity as well as integrity of the cells, they don't detach off and float off the surface, as well as morphology. Morphology is a little complicated because cells can look rather large in the tube. They can even look kind of creepy looking and not really be stick. So it is a fluid concept, but basically multi-layered, loss of polarity. Cells may be detaching or fragmenting off the surface. And usually your MIB is going to be over 20%. And that's sort of, I'd also do a P16. Good question.
Thank you so much for the wonderful talk. My question is more about like, have you interacted with the comparative pathology? This type of process is described. Like depending on different species, animals. Is it seen in other animals?
Oh, comparative, yes. I think in chickens in particular, they do get cancers. I don't know. I actually collaborated with someone who was a comparative pathologist once trying to figure that out. We didn't have good antibodies to look at that. But they do, I think in chickens, they do get fallopian tube-like cancers. And I think that's one of the biggest arguments for fallopian tube being an origin of their cancers. I'm trying to think about I don't know right off about any other animal models that natural. There have been a number of, mouse models, which have been induced by introduction of mutations into fallopian tube epithelium, which have produced a similar scenario. But it's mainly the fowl, and mainly it's the chickens.
So in the GI world, there's a lot of discussion about how most chronic adenomas do not progress to adenocarcinomas. Do they just stick around and do nothing, or do they regress? When you're looking at the sticks, obviously this is something that's very hard to follow, but if you don't know from cancer, do you think they regress, or do you think they just sit there?
Yeah, when I look at a precursor in the tube, I think, just to back up a second, a lot of these so-called signatures, we call them, are short. If you look at like a leaf brown mini fallopian tube, because they already have a haploinsufficiency of p53, they're loaded with little signatures, usually without much atypia. When you move on to the larger lesions that begin to occupy a plica, then I begin to worry because they probably have a growth advantage. I think most of these probably develop a p53 mutation, they live out their lifespan, and they stop at 20 cells. Probably. But I think when you have a plica involved or a larger area, there is some growth advantage, which probably increases the risk that something else could happen. As far as sticks, I don't think they go away, but I don't know. I think a lot of them may never do anything. And I've seen cases where you get a woman coming in, her sister gets cancer when she's 70. She's 2 years younger. She comes in and has her tubes taken, and she's got a stick. Then she brings her daughter in at 45, and she's got a stick. But I don't think they necessarily happened yesterday, right? They've probably been there for a long time. So I think a lot of sticks just sit there. And I think, stick is not really very common. I mean, you don't run, I think it's been estimated to be like about 1 in every 1,100 women are walking around with a stick in their fallopian tube. And if only a subset of them are going to get cancer, I think it begins to give you an argument that a lot of these cancers are not coming out of sticks as we know them, right? They may be coming out of a very short-term event. And I think that's probably what's happening, but that's an argument that's only based upon that. What always interested me about colon was some of the more recent arguments that colonoscopy wasn't really altering the death rate as much as I thought it did. I know that I've seen the graphs, which I thought looked good, but it raised the question for me is, I think people do claim that a lot of colon cancers do come out of polyps. Do you think some of them are short-lived lesions that come out of polyps? I mean, the serrated adenomas that I never thought did anything, are they really important now?
They are very important. I think it's a tough question to answer. And we're also seeing a lot of things happening in young patients now, far more than we used to. I guess the question is, are we underdiagnosing some of the serrated polyps and leaving them as hyperplastic polyps when actually they're serrated adenomas, lesions, whatever terminology you like? But yeah, it's a hard question to answer, and some of them do seem to be coming back nowhere.
We've had a number of ovarian mucinous tumors that had serrated adenomas in the appendix, and we're always told that they're not related, and we keep saying, I don't know, something's crazy going on here. But some of our GI pathologists are more hard fast about not buying that yet. So I don't know. But yeah, but thanks. I agree. That's all I can say about the fallopian tube. We don't know any more than anybody knows in the GI tract problem.
Maybe one more question. Thank you very much. Can you please comment on routine practice reporting on low-grade serous precursors such as still?
Yes, generally, if you may occasionally run across very short lesions like little signatures that probably don't need to be mentioned. If we do, we'd say like a benign proliferation or benign change, unrelated. For stills, to me, a still, if it's large enough and it catches your eye, we would generally call them serous tubal enteropathy lesions of uncertain significance, and we would make the comment that it is not diagnostic of stick. We counsel the physician that it does not require additional management or any actionable. We don't really know much about the natural history, but assume that the risk is very low. And perhaps, obviously, that's sort of lower than it would be for stick. But occasionally something happens. I'll just show a case today that's a little bit like that, but they're not great. I've tried to look up stills to see what happened to the ones we diagnosed, but often the patients are relocated or gone. I think most of them never do anything. I think it's if they're really on the verge of stick, though, I think that obviously you have to if you're really not sure if it's a stick or not, tell them that. They still may not do anything, but if it comes back, they've at least been forewarned. But that's only occasional that you're going to have that particular problem.
Sorry, I think
Sure.
one more. We're good. I think we have to move on. There's one more question. I had a recent RSO from Red 51 carrier that had stick with bilateral 1 to 2 millimeter ovarian serous carcinoma near the surface. Do you think there's something on the ovarian surface that traps the tumor cells?
No, it's a legitimate argument. I would say that in our experience, we usually would level the tubes. You know, and we've had cases where we had ovarian surface epithelium. You had to go to 2 or 3 levels to find the lesion. You may not find it, but I would do that first. And then I'd be thinking it could be a primary perioral process, perhaps, if it's that superficial. I think the odds that it would start on the ovarian surface would be low at this point.
Thank you very much for an excellent presentation.
Okay.
Hi, everyone. Thanks for sticking around for the last hour of this day. It's a privilege to be a part of the Unity Health Roderick Ross Day and to have our community of interest kind of close out this really nice group of presentations. As always, we're going to have some presentations from our guest speaker, Dr. Crum, and we're also going to have some presentations from some of our members of our community. And we're going to start just with Dr. Plotkin, just saying a few words, who is the Director of Continuing Professional Development from the University of Toronto. So Anna?
Yes, hi, good afternoon, everybody. And I want to echo and thank Unity Health, Yuyun and Kathy Strutker for inviting us to be part of this excellent event. I just want to tell everybody that the CME certificates will be issued only for the community of interest portion for physicians. And please remember to fill out the evaluation form. Those of you who are in the Unity Health or live at other sites, please take a paper attendance so we can record it for our CME certificates. And with that, Anjelica, I think it's back to you.
Yeah, great. Thanks, Anna. So we're going to give Dr. Crum just a break, and we're going to have our first participant. So that is Dr. Roman Zyla. So Roman, I hope you're ready. Roman is
I'm here. Can you hear me?
Yeah, great. Roman is our Gynecological Pathology fellow at UHN, and he's prepared a couple cases to present. So Roman, go ahead, you can share your screen.
Can you see my screen?
Yep, great.
Okay. All right, well, thank you very much for the kind introduction, Dr. Hodgson. So this is going to be a whirlwind tour of 3 classic examples of 3 relatively rare sex cord stromal tumors. of the ovary. So I'll get right into it. And the first case, is this patient is a 40-year-old female who presented with symptoms of right lower quadrant pain, presented to hospital, and on ultrasound was found to have features of ovarian torsion on the right side. Was also found to have an incidental left ovarian quote unquote cyst on the left side, which was actually found to be a solid mass on the left side intraoperatively. So she had a torsion on the right, but this incidental 5 to 6 centimeter solid mass on the left. And on gross examination, it was found to be well circumscribed, about 5.5 centimeters, tan yellow with multiple well encapsulated nodules on cut surface. And that nodularity is something that you can really appreciate on low power here microscopically. And going to intermediate power, you get this, again, impression of nodularity, vague nodularity, with the lesional tissue composed of sort of solid to cystic appearing areas, at least on intermediate power, divided by these bands of hyalinized fibrosis. But on high power, you can really see that almost all of the lesional cells are arranged in tubules, and some of that what looks sort of cystic. It's you have tubule formation with intact lumina, and then a lot of compressed tubules that give you this impression of solid growth on low power. But in fact, this is almost all tubule formation. And sorry, I should just comment that the lesional cells themselves are cuboidal to columnar with pale cytoplasm, sort of bland nuclei, and minimal mitotic activity. By IHC, these cells stain for a number of sex cord markers like SF1, inhibin, calretinin, and they're negative for CK7, PAX8, TTF-GATA, neuroendocrine markers, hormone receptors. So molecular testing was done on this case, and the tumor was found to harbor a VUS and STK11. Just to show you a representative slide of SF1 staining, diffuse strong staining. So this is a Sertoli cell tumor. So these tumors can present at any age. They can be asymptomatic, which was the case here, or present with hormonal manifestations of androgen or androgenic or estrogenic manifestations. They can be associated with STK11 mutations as well as DICER1 mutations. They're typically solid with tubule formation being the most common microscopic architecture. The vast majority show benign clinical course, though those with high mitotic rate, necrosis, and nuclear atypia may behave more aggressively. They're typically positive for these sex cord markers, negative for neuroendocrine markers, negative for TTF-GATA. So that helps to exclude some of the common mimickers like mesonephric-like tumor or mesonephric-like carcinoma or low-grade endometrioid carcinomas, neuroendocrine tumors, etc. So that's case one. I'm going to keep running. So case two, this is a 32-year-old female with elevated BMI and PCOS, presented with abnormal uterine bleeding, was found to have a FIGO1 endometrioid adenocarcinoma on biopsy, had an unremarkable preoperative ultrasound, underwent THBSO. At gross examination of the specimen, the right ovary was noted to be somewhat larger than the left, but there were no focal abnormalities commented upon. You can see here right off the bat on low power that you have a neoplasm here involving the ovary that's relatively well circumscribed and well demarcated from the background ovarian parenchyma. On sort of intermediate power, you can see that this lesion is composed of islands of epithelioid cells embedded in this fibrocollagenous stroma. On higher power, you can see these cells are epithelioid. They have abundant eosinophilic cytoplasm, round central nuclei with, again, minimal mitotic activity and no significant atypia. By immunohistochemistry, cells were positive for SF1, WT1, CD10, cyclin D1. They were negative for inhibin and calretinin, as well as these other stains I have listed here. And the real kicker in this case is these were positive for nuclear beta-catenin. Unfortunately, I don't have that access to that slide, which would have been nice to show. But so this is an example of a microcystic stromal tumor. These, again, present with a wide, can present at many different ages. They typically present with mass effect. It's unusual for them to present with any sort of hormonal manifestation. Again, typically a benign clinical course. They're associated with dysregulation of the Wnt pathway. So you can have mutations in CTNNB1, but you can also have APC mutations, and a subset of cases do arise in the syndromic setting in patients with familial adenomatous polyposis. Grossly, they're typically tan, white, solid cystic masses. Classically, they have a predominantly microcystic architecture. This is an example of a case with predominantly solid architecture, so it didn't really have any conspicuous microcysts. Nuclear beta-catenin is a key immunohistochemical finding, and it's just important to note that they're positive for SF1, but they are typically negative for inhibin and calretinin. So, if you were to do just those two stains, you may sort of prematurely exclude a sex-cord stromal neoplasm from your differential diagnosis. So it's important to keep that sort of pitfall in mind when encountering a tumor that looks like this in the ovary. And so the last case, case 3, this is a 31-year-old female presented with abnormal uterine bleeding, and an ultrasonography was found to have a 7-centimeter solid right adnexal mass. So she underwent surgery, and again, at gross examination, she had this solid mass, 6.8 centimeters, that on low power has this, you can see what they call a sort of pseudo-lobular growth pattern. So you have more hypercellular areas that are interspersed by this hyalinized stroma that gives this impression of a lobular growth pattern. On intermediate power, you can really get an appreciation of this dense collagenous stroma and the sort of nodular growth or pseudo-lobular growth again of the lesional cells. And this tumor, as other examples of this tumor, had these so-called staghorn or hemangiopericystoma-like blood vessels. And on high power, you have this admixture of sort of fibroblast appearing spindled cells with more epithelioid cells that appear conspicuously luteinized. By IHC, again, positive for multiple sex cord markers like SF1, inhibin, calretinin, as well as synaptophysin. This was negative for WT1, pancetokeratin, chromogranin. Beta-catenin in this case was membranous, and this tumor was also subjected to molecular testing and was found to harbor an FLH2 GLE2 translocation, which helped to confirm the diagnosis. So just to show you again a couple of representative immunos slides. So this is a sclerosing stromal tumor. These typically present in adolescents and young adults, as was the case for this patient. Again, they can be asymptomatic, which was the case here. They can present with endocrinopathies or with symptoms of mass effect, and again, typically have a benign clinical course. They're solid, typically on gross examination, though they can have some cystic changes. And the classic architecture is this so-called pseudo-lobular growth pattern with epithelioid and spindled cells separated by edematous to fibrocollagenous stroma. Again, they have these staghorn blood vessels, positive for sex cord markers, negative for pancetokeratin and EMA. And the large majority of cases have been found to harbor these GLE2 rearrangements, as was the case in our tumor. So in summary, we've seen a Sertoli cell tumor, microcystic stromal tumor with predominantly solid growth, and a sclerosing stromal tumor. So these are just 3 somewhat classic examples of relatively rare sex cord stromal tumors that Dr. Hodgson and I wanted to share with the group. Thank you very much for your attention.
Well, thanks, Roman. Dr. Crum, I will invite you up here first to comment about your experience with any of these, any pearls or pitfalls that you have with these types of tumors.
That's beautifully presented. There were 3 great cases.
Yeah, it's I find it especially the Sertoli more difficult sometimes because you're always looking for the Leydig cells, right? But the other 2 with the characteristic molecular changes and the nuclear beta-catenin, it's always so satisfying when you can name that and put a specific name to it.
You get mixed tumors too. Sometimes you get minor components of Sertoli, and then it becomes a little more difficult to diagnose. I think my own experience historically is if it's a tumor that's a little odd looking at, and I don't know exactly what it is in a fairly short time, it's probably a Sertoli cell tumor. I mean, for me, just because they tend to be the more heterogeneous in the way they can present. You know, going from very poorly differentiated to classic. Well, that was a beautiful case.
Well, when you put the picture up of the Sertoli, all I was thinking was, wow, that looks like fat. Well, I was certainly consider that it's in the differential, right, when you start to have those tubules and stuff. But okay, Julian, I'm sorry, I don't know how to operate this. Can we just make sure there's no questions? Anna, any questions from the audience, virtual audience?
No, I don't see any questions, but please remember to put your questions in the chat. I will be monitoring and ask the questions on your behalf. Thank you.
Okay, well, in that case, perhaps we will let Dr. Crum present his first case.
I'll do one. Yeah, I don't want to take too long. Okay. Case one is a vulvar mass in a 60-year-old patient. This was a case that I got in consultation from Rhode Island. It was a circumscribed mass surrounded by adipose tissue with a variety of appearances. Somewhat higher power, you can see it forms glands and a dense, sort of almost desmoplastic type stroma.
I'm sorry, we don't see anything in the Zoom world.
Going to overrun. Okay. So this is case one is a vulvar mass in a 60-year-old. It's a circumscribed mass I got in consultation in the vulva. And they were asking us, what did we think of it? At a higher magnification, part of the mass has these well-defined glandular structures that are encased in dense desmoplastic response. Another area, the glands are somewhat less distinct, as you can see here. And when I was looking at this case, I was thinking back to a previous case. The previous case is one that we had a gain of vulvar mass in a woman about the same age several years before that was composed of these, tubular areas along with some mild spindled stromal type changes. And when we looked at this thing, we ruminated over it, wondered about some form of epithelial tumor. The fact that there was a little bit of a spindle component made us also think about certain things like mesonephric-like tumors or mesonephric carcinomas because of the appearance. Another concept was could it just be some kind of Mullerian carcinoma, like an endometrioid carcinoma with a spindle component. It also had areas like this, which were somewhat more polypoid. The stroma was rather bland, so we didn't think about adenosarcoma at the time. So our diagnosis of the things that we considered, for 1A, the one that we're talking about is a hydradenoма or an adnexal carcinoma, a mixed pattern Mullerian carcinoma, mesonephric carcinoma, or something else. The outcome of 1A was this patient received platinum-based chemotherapy and radiation. No tumor was found a year later. The patient returned 4 years later with a hepatic tumor, diagnosed as metastatic synovial sarcoma. That was the second case I showed you. And she had chemotherapy, which was changed to adriamycin. She died of disease a year later. So in that case, we classified it as a Mullerian carcinoma. We were incorrect. And it turned out that she actually had a synovial sarcoma, which presented on metastases. I went and spoke with the patient, and we discussed it at length at the time. And I explained to her that we had shown it, had gotten everybody to look at it, and that had been the diagnosis, the first diagnosis. So I'm sitting here looking at this case about a few years later, and I'm saying, and we've been looking at it for about 2 weeks. And I'm saying, now what? I don't want to misdiagnose the synovial sarcoma if it could be. And I don't want to just make the diagnosis of, without at least by taking a chance. I want to be sure about it. So I started looking at it more closely because I'd shown it to a lot of people. Is this an adnexal carcinoma? Our division had seen it. And the thing that caught my eye was that if you looked in between the glandular cells, there was a little stroma and it was a little bit abnormal. And with that, I decided this is probably a synovial sarcoma. And so what I did was then we went ahead and got a TLE1 stain, which was intensely positive, both in the glandular component and in the stromal component, because they're both obviously going to be TLE1 positive. But it's interesting, if you look at the the area where you had the desmoplastic change, it's TLA1 negative. So there were areas of that tumor that just looked like a typical invasive desmoplastic adenocarcinoma. And in this case, as you can see, that desmoplasia does not stain, only the tumor. So the diagnosis in the first case, which of course was the second case, was a synovial sarcoma with prominent epithelial differentiation. And the take-home lesson was the spindle component can be subtle. Actually, the first couple of cases we looked at, the spindle component was there, it just was very bland. In the second case, it was more subtle. And the other important thing is there's an absence of involvement of appendages or surface epithelium. So any deep-lying tumor that is not really attached to the surface, you've got to keep in mind the possibility of something other than a typical epithelial tumor. And we actually put our case in David Colin's paper that we published a couple of years ago. Just as a corollary, case 1B, which is this another case, it's a case where you have a somewhat deep-seated lesion beneath the epithelial surface, and you start looking at higher power, it's very epithelioid, it's high grade, it looks malignant, obviously. These polyhedral cells with marked nuclear atypia, prominent nucleoli. And the differential diagnosis again comes up as a squamous carcinoma, adnexal, metastatic, mesenchymal neoplasia. And of course, what was done was a SMARCA4 stain, which comes up negative. And so what you're looking at here is just a nice example of an epithelioid sarcoma. So I think these are good examples of mesenchymal things that can mimic epithelial. We learned our lesson on that first synovial, and we saw a lot of cases after that which were very easy. They were just no-brainers, even ones that were rather subtle that other people didn't recognize. Anyway, this is what you find with the epithelioid sarcoma. Again, high recurrence, poor outcome. Two examples of rare tumors. It is as I said before, it's the rare tumors that are going to get you. It's a rare tumor that not the rare tumor that gets you. It's the rare tumor that looks like something you commonly see that can trick you. If it's not associated with epithelial surface, consider alternatives to a primary epithelial malignancy. In this case, a mesenchymal tumor. So that's it.
Yeah, Dr. Crum, if I could just ask you to stay here just for a minute. I mean, my goodness, I think two things from your first case. I think, as you alluded to, when the spindle component is so bland, you don't even recognize as part of the tumor. That's the scary part.
It can even look squamoid a little bit.
Mm-hmm. Yeah. And then even if you do recognize it as part of the tumor and you come to the conclusion you're dealing with a biphasic neoplasm, I don't know if anyone else agrees, but typically synovial sarcoma is not in my differential of a biphasic tumor in the gynae tract. So even then, I don't know if we would get there. And it looks so glandular, like.
Fortunately, it's pretty rare elsewhere than the vulva. There are rare reports in the pelvis, but they're vanishingly rare, at least in the GY tract.
And epithelioid sarcoma, those you can really go down the tubes with calling carcinoma as well. And they stain with epithelial markers.
Yes.
And GATA3, I've seen one where someone called it a kind of memory type carcinoma in the vulva. Luckily, the SMARCs kind of can get you out of that, problem.
You got to think of it.
If you think of it, exactly.
Luckily, that wasn't my case, so I think somebody else thought of it.
Yeah. Hey, well, that's good. Good to have good people around. Anna, anything to add or from the chat?
I don't see anything in the chat.
Okay, wonderful.
Okay.
Thank you. So we will keep alternating, and our next person is Dr. Olga Moshkin from Peterborough.
Dr. Moshkin from Pathology, Department of PRHC, Peterborough Regional Health Center. Thank you very much for inviting me, and hello, everyone. I will present a case of 49 years old female patient who came to attention with severe uterine bleeding and actually advanced gynecological malignancy, clinically suspected uterine sarcoma with multiple metastases in the abdominal cavity, liver, and lung. On low magnification, you can see very busy specimen composed of fragments of cellular tumor with large areas of necrosis and hemorrhages. Medium magnification, you can see again cellular tumor, vasculature, some branching vessels, some sinusoidal type vessels, and a very thin, delicate vessels arborizing. Higher magnification show areas where we can see like nesting pattern, epithelioid-like cells, here spindle cells whirling about around the vessel, and rosette-like structures. By immunohistochemistry, tumor was negative for pankeratin, positive for CD117, positive for vimentin diffusely. CD34 highlighted multiple vessels. Ki67 very high, more than 90%. P16 patchy positive, P53 wild type. And overall, as I already listed, positive stains for vimentin, CD117, P53 wild type, P16, Ki67 high, and negative staining with pankeratin, CK818, EMA, P63, cytokine 7, PAX8, ER, S100, etc. You can see all the panel I did to exclude everything as possible, which look like kind of small round cell focally, kind of epithelioid and spindle cells. And my diagnosis was high-grade malignant neoplasm with sarcomatoid features. I sent this case for consultation for Mount Sinai Hospital. At Mount Sinai Hospital, additional stains were performed and showed CD10 positive, cyclin D1 overexpression, repeated desmin, SMA, H. Caldestone negative, PR negative, HMB45 MART1 negative, P53 normal wild type, and MIB label index high. And by molecular analysis, consultant diagnosed a high-grade endometrial stromal sarcoma with YWH18 not M2B fusion genes. So final diagnosis, fragments of high-grade uterine sarcoma in keeping with high-grade endometrial stromal sarcoma. And a few words about endometrial stromal sarcoma. WHO classification of endometrial stromal tumors now recognized 4 groups: endometrial stromal nodule, low-grade endometrial stromal sarcoma, high-grade endometrial stromal sarcoma, and undifferentiated uterine sarcoma, UUS. And this classification was based on molecular alterations, morphological, and prognostic differences in these 4 groups. There are 4 subtypes of high-grade endometrial stromal sarcoma: WYHNE not MAB fusions, B-core rearranged, B-core internal tandem duplication ITD, and high-grade transformational low-grade endometrial stromal sarcoma. All of those types has the specific morphological changes and the specific immunohistochemical appearance. High-grade endometrial stromal sarcoma, this I gave a short description of what we can see morphologically, but it's more related to sarcoma, high-grade endometrial stromal sarcoma with YWHNE not M8 fusion. It's generally speaking, all endometrial stromal tumors are rare neoplasm, but high-grade endometrial stromal sarcoma is very rare malignant neoplasm. All those groups originated from endometrial stroma, which resemble endometrial stroma of proliferative type endometrium. So all those groups characteristic by uniform cytologic atypia without prominent or pleomorphic changes in cells. For these tumors, specifically high-grade endometrial stromal sarcoma, characteristic permeative tongue-like invasion, uniform cytologic atypia. It can show sheets on nests of cells, round cells, epithelioid cells, or spindle cells. May have the second component, which look low grade. Second component, usually high mitotic rate for high-grade ESS, more than 10 mitosis and 10 high paraffil, necrosis, which could be tumor necrosis or infarcted necrosis, and delicate network of arborizing or curvilinear vessels. Variable positivity for B-core cyclin Li1, CD10, pan-tipiret CD117 depends on molecular alterations, and almost all high-grade tumors are negative for AR/PR and only focative positive for smooth muscle markers. Genetic alteration, as I said, YWHNE, not M2AB fusion, B-core fusion, and internal tandem duplication. Differential diagnosis for high-grade endometrial stromal sarcoma include low-grade endometrial stromal sarcoma. This included in differential because of actually all of them has very monotonous uniform cytologic atypia, leiomyosarcoma, undifferentiated uterine sarcoma. The last one, a lack of any molecular alterations. For high-grade endometrial stromal sarcoma with YWHNE not M2AB fusions, undifferentiated carcinoma could be included in differentials because sometimes this sarcoma shows pseudoglandular, pseudopapillary, or rosette-like formation. For high-grade sarcoma, B-core rearranged, myxoid leiomyosarcoma, and inflammatory myofibroblastic tumor included in differentials because this type of sarcoma has prominent myxoid changes in the stroma. In addition, in differentials included picoma, uterine tumor, resembling ovarian 6-core stromal tumor, carcinosarcoma, and adenosarcoma with predominant sarcomatoid component, specifically on DNC specimens. And I included melanoma as well because, as you see from my picture show them, there are many epithelioid nesting cells which could resemble melanoma. Metastatic nodule after previous surgery, metastasis could be very late. Differentials again could include melanoma and GIST because sometimes sometimes metastatic high-grade endometrial stromal sarcoma could be positive for CDA117 and DOG1 as well. And treatment options, the first line of treatment options included total hysterectomy, preferably with no marcellation, and bilateral salpingo-oophorectomy, ovarian preservation, fertility sparing treatment, and adjuvant hormonal therapy plus minus radiotherapy may be an option in selected cases as well. In advanced or recurrent cases of low-grade endometrial stromal sarcoma, surgical cytoreduction followed by hormonal treatment or vice versa are acceptable as well. The standard treatment for apparently early stage high-grade endometrial stromal sarcoma and undifferentiated uterine sarcoma is total hysterectomy without marcellation with bilateral salpingo-oophorectomy. Ovarian preservation could be considered as well. And in advanced cases, surgical cytoreduction, neoadjuvant and adjuvant chemotherapy can be considered as well. Now, great attention was taken to alternative treatment, including targeted drug therapy or immunotherapy. However, the number of cases very little and it is under investigation. And thank you very much for your attention. And I would like to say a huge thank you to our gynae consultant from all hospitals we're working with for ongoing help and education.
Well, thank you, Olga. Difficult case when you get something that's so kind of solid and just kind of ugly on a biopsy. I'll ask Dr. Crum to make his way up here. And while he's on his way up here, think about if he could give us his approach to mesenchymal neoplasms. Any tips or tricks for our colleagues, especially on biopsy specimens?
Well, I think it was pretty thorough when you're dealing with, I think we try to think when you're dealing with these tumors and particularly the high-grade stromal sarcomas, they're kind of pleomorphic. You know, they can be very classic. They can also be very bland. And so we generally always try to remember to do the appropriate immunostains to exclude it because they don't always, you know, a low-grade one's pretty straightforward. You know, and a classic leiomyosarcoma is pretty straightforward. But when you get into the high-grade stromas, you have to remember to do this. We always do the stains just to make sure.
What about, you always do the stains, do you always do molecular?
I think in general it will be sent for molecular.
Yeah.
because they're not that common. We're not like we're doing it every single day.
Mhm. Yeah.
But that's an entity which obviously has made a big difference in how we look at stromal tumors, because for several number of years, no one was allowed to call anything high grade, as you know. So, and of course, that's morphed out into all these others like B-core and others that have, and they continue to be discovered on a regular basis, new gene rearrangements or biomarkers that separate them.
So lumping and splitting, so you think they all should be split, right? We
Well,
should
they're
keep
splitting them, and
looking-
they'll split until they find treatments for them.
Right, yeah.
For sure.
Okay, great. So we'll continue on with Dr. Crum's next case.
Okay, this won't take too long. It was another miserable case. This is a woman who presented with a pelvic mass. She had a cul-de-sac mass that was fairly large. It was fixed, and the cervix and uterus were normal to examine. She had a prior history of HPV-associated disease in the past. This is what the case looked like. It was a rather monomorphic population of slightly round cells with fairly noticeable cell borders. And when we were looking at this case, we didn't really know exactly what it was, and we started to stain it. The preliminary impression was, a monomorphic population of epithelioid cells with indistinct variable cell borders, epithelioid features, and no squamous or glandular differentiation. We started off with an A1, A3, and we were fairly confident that it obviously was epithelial-like, and that there was strong staining for the cytokeratin markers. We then did a P63. When we did that, one of the fellows said, "Oh, this must be a squamous cell carcinoma." I said, "Well, it's positive, but it doesn't look all that squamous to me. And I've seen a lot of squamous carcinomas, but that was what the fellow thought it might be." Then it came out to be strongly P16 positive. And at that point, we also did a nut stain just to make sure it wasn't a nut. And we also did HPV testing. And I'll get to that in a minute. So in summary, this was a prior history of cervical L-cell 15 years before, cul-de-sac epithelioid mass, strongly positive for A1, A3, P63, P16, negative for nut, negative for high-risk HPV. So what you got to be careful about when it's negative for high-risk HPV, you don't necessarily tell them that it could still be HPV. Because if you tell them that, then they're going to tell everybody it's an HPV-associated neoplasm, even though it's negative. It's better just to say it's negative for high-risk HPV. And I think they were initially given this impression, and they would say, well, this is some kind of, HPV thing. I said, no, the best we can do is give you some kind of epithelioid neoplasm of probable Mullerian origin. And this was based upon taking it to our own consensus conference about 3 consecutive weeks as we tried to figure this case out with no real resolution. Follow-up. So the patient was treated for presumptive Mullerian epithelial malignancy with platinum-based chemotherapy. And she actually had some improvement of the symptoms, although no appreciable change in tumor size. The follow-up molecular testing showed a STAT6 rearrangement. So what this was an extremely rare example. Here's the STAT6 stain. And you can see there is a staghorn vessel pattern. And so the same resident that was telling me it was squamous said, "Oh, this is obviously a solitary fibrous tumor because look at the staghorn vessels." I said, "Well, why didn't you tell me that about 3 months ago?" So it was funny. We went to tumor board, which you hate to go with a case like this. And we get the tumor board, and the oncologist says, "Patient feels 10 times better. The patient has urinary symptoms are better." I think the oncologist was rather disappointed because the tumor hasn't done anything. Maybe she's mad at the patient for getting better, despite the fact that nothing happened to the tumor. So in the end, it was a solitary fibrous tumor. And we began to go through the literature, and there are rare examples that are positive for P63. When I was diagnosing this case, I considered a mesenchymal tumor, and then I pulled out a rather extensive review of mesenchymal tumors for P63 from our own department. They did mention this tumor, but then again, if you look through the literature, solitary fibrous tumors, most of them are P63 negative. But someone we dug up a couple of cases where it does happen. In fact, one case we found in the literature was diagnosed as a metaplastic breast cancer until it didn't respond. And then they found that it was a solitary fibrous tumor of the breast. So it's a good take-home lesson in this case. You know, take-home lessons, you can show at a consensus conference every week without ever getting closer to the diagnosis. It's very important to realize the collective mind can be no mind at all at times, which is what my wife always tells me, particularly before lunch. So, you know, they're all sitting there, they want to go eat. I remember Doug Levine, who was a well-known oncologist, used to say at an NIH meeting, if you're writing a grant, make sure they could read it. They understood exactly what you're doing in the first 2 sentences, because everybody on the committee was looking at their iPhone. You know, that it's not that bad at our consensus conferences. I think everybody pays attention, but no, you don't always get an epiphany from somebody sitting in the audience. If it's HPV negative, don't mislead the clinician. Well, it could still be HPV positive, because they will take that to the bank. They'll take it with them, and you may find it in the chart somewhere. I had a relative one time who had a mass at the top, actually in the lower uterine segment, which was diagnosed initially as a tumor of the cervix. I looked at it and said, this is not cervical. It was resolved, and to the day she died, 3 years later, the chart said cervical cancer, and she took it with her thinking that she'd made some mistake by not being screened on more common. I mean, it had nothing to do with it. It was a uterine cancer. So things will be stuck in the chart that will stay there forever. And the ability to change that is very difficult. And show it to your soft tissue pathologist if it does not have a growth pattern you're unfamiliar with. I don't know whether ours would have picked it up. When I told it Jason Hornick that it was a solitary fibrous tumor, he said, I don't believe that. I said, well, believe it now. But he was maybe just being kind. He didn't realize they could be P63 positive. So there you have it. No questions allowed. No,
Yeah.
it was a good case.
Good case. As you said, I mean, geez, SFT that's so epithelioid, like, ooh. But the vessels seem to be quite characteristic. I thought you were going down the road of when you first said, oh, epithelioid, P63, I was like, oh, okay, trophoblastic. That's where I thought
Well,
you were
yes,
gonna
we
go
consider that we
in
did.
cervix and stuff.
Yeah, we
but,
stand for that. Yeah.
difficult, very, very difficult case. Tough. And you mentioned, you know, just you're showing the cases is wonderful, but all your take home lessons are just as wonderful, I think, that you're giving us.
It's interesting. There was a paper published on treating solitary fibrous tumors. And they went down a long list of chemos, including platinum. And the response was, no matter what you treated with, there was no progression. Meaning it's a euphemism for an indolent tumor that is not going to go away, but it's not going to progress. It's not going to get bigger, and it's not going to get smaller. So basically, chemo doesn't affect this tumor. The oncologists were left with, you know, maybe they'll give radiation to get it smaller to get it out, but I don't know if they've got many options, you know, but the patient felt better, which I thought was nice. And I think it may have changed, reduced some of the pressure, you know, maybe she got a little bit of it. So, yeah, good case.
Anna, anything online?
No, I don't see any questions.
Oh, okay. So then we will have Dr. Sharon Nofek-Moses present her case and discussion, and then we will end with Dr. Crum. So Sharon, please go ahead. Sharon, Dr. Nofek-Moses is a pathologist at Sunnybrook here in Toronto.
So my case is going to be very much a common case. I'm a little bit intimidated by all these wonderful presentations of very difficult cases. So the patient is 62 and she was referred to our institution after she had a biopsy done for premenopausal bleeding, and the biopsy was read by gynecological pathologists outside as endometrioid FIGO grade 2 cancer, and right there there were some biomarkers done. It was noted to be subclonal loss of MLH1 and PMS2, and also was interpreted as P53 normal. So in our practice, we would not have reviewed that case being signed out by a gynecological pathologist. So she underwent a hysterectomy with bilateral salpingo-oophorectomy and omentectomy. There was no lymph node resection here because of technical issues. She bled quite a lot during the surgery. And you can see here a low magnification of the tumor. The tumor is kind of anchored in the lower uterine segment. It is superficial, as you can see here. And although it is going towards the cervix, actually it was not involving the cervical stroma. You can see it here on a higher power, and you can also see that when you look around, there is actually sheets of solid growth. In some areas looked a little bit less cohesive, but in other areas it was well cohesive. There were other areas with some abortive glands and a hint of squamous differentiation. So overall, we felt that it had an endometrioid histology. I want to draw the attention to the presence of lymphovascular invasion, and I have marked here 5 yellow circles, but I could actually go on and mark maybe another 1 or 2 areas. And overall, to summarize, this is a high-grade endometrioid adenocarcinoma, a FIGO grade 3 with inner half involvement, lymphovascular invasion in 5 or even more in that one slide that I have shown you. The cervix, fallopian tubes, ovaries, and omentum are all negative. And as I mentioned, the lymph nodes were not done. So I want to ask you a question. I'm not polling you or anything. I just want you to think about this question because it will set the stage for the discussion about that case. So my question to you is, what is the stage that you will assign at the end of the synoptic report? So my options to you is unstaged because we don't know the lymph node status. According to AJCC, will be a 1A. According to FIGO, will be stage 2. And another thing would be FIGO recommends clinical staging for endometrial carcinoma. So just think about the options. Because this was a high-grade tumor, as well as this subclonal expression, subclonal loss of MLH1 PMS2, we proceeded with full molecular characterization. And while we wanted it, or we thought it's going to be polymutated, it was not. We found some mutations in PIK3CA, PTEN, and KRAS. These are all well characterized in endometrial carcinomas. The tumor was expressing very focal ER, only in 1% of the tumor cells. PR was negative, and we did a HER2 testing based on the discussion in the multidisciplinary rounds, and it was HER2 negative. And just to remind everybody, P53 was normal in this case. So our integrated report was high-grade endometrial adenocarcinoma, endometrioid, MMRD. And really, I wanted to bring this case as a teaser for the new FIGO system so that everyone in the community and around us will know that last month there was a formal publication of a new FIGO staging system. And in this system, there are biological, i.e. the molecular subtypes, and aggressive histology incorporated in the staging, as well as LVI. And this creates some discrepancies from what we are currently, or until recently, practiced with the staging based on AJCC. And I will only concentrate here, because of the limited time, on or at the low stages. I see that I have only 3 minutes left. I want to highlight that there is distinction between aggressive and non-aggressive subtypes. And there is a whole respectful place for substantial lymphovascular invasion. Because of lack of time, I don't want to go into the subtleties of that. I will just say that the aggressive subtypes are the known high grades, but in addition, we would account for the molecular subtype. So if we have found polymutation, regardless of the histology, it is getting a stage 1A. And if it is a P53 abnormal, it will become a stage 2CM, M for molecular. That's for cases even without any myometrial invasion. So that's about the aggressive subtype. And about LVI, we are now not only required to say whether it is present or absent, we need to say whether it's focal or substantial. And for this, we will just remind ourselves that there are some mimickers, such as MELF, retraction, displacement, or pseudo-LVI. And what is substantial LVI? So substantial LVI means that we have seen it in 5 or more vessels in the case. Now, although it is not actually published in the either WHO book or in the FIGO staging paper, the pathologist on the study, Dr. Matthias Guyo, spoke with me, and he stated that this can be counted in as many blocks as you want, and whether or not you use immunohistochemistry, it doesn't matter, as long as you hit the magic number 5. So the actual evidence for this magic number 5 is not very well anchored in science. And the scope of my presentation is under that discussion of whether or not it should have been. I just want to tell you that there is such a staging system, and 5 is your magic number. So maybe we need to soon consider having at least a comment or another line added to the AJCC until the current checklist is available, because the clinicians will start to ask us, if it's more than 3, is it also more than 5? We will not have time to talk about that. So for our teaser, the case that I have shown, this is a case where we have superficial stromal invasion, but we had high grade endometrioid, and it had more than 5 vessels. So overall, this is a stage 2C based on molecular, based on the aggressive subtype. And if this would have been, as initially stated, grade 2, we would still have it as a stage 2 because of extensive LVI. So just to reflect back to my question, according to AJCC, it would have been a 1A with the FIGO 2023. It is stage 2. And if someone wants to argue that the case is unstaged, this is true because there were no lymph nodes taken here. So actually it is at least FIGO stage 2. Yeah, so just to let you know that this has not been very well received all over the world. And there is a review paper published basically criticizing the way FIGO came up with the staging system. But regardless of that very respected scientific discussion, we still need to practice in a world where our clinicians are going to use the new FIGO system for staging. So that's it.
Thank you, Dr. Nofag-Moses. Dr. Strutker has given us permission to go a little over time, so I'll invite Dr. Crum back up. And as he's coming up, I will ask him to give us his opinion on the FIGO 2023 staging.
Well, I think it's probably a little preliminary, but it's an effort to push the envelope and then see how it sticks.
Yeah.
Yeah.
Yeah, I think I mean, as Dr. Nofag-Moses said, and Carlos is the senior author, that essentially every pathologist that I've spoken to about this is not a fan. Many surgeons are not a fan. I've heard some medical oncologists say that they appreciate this because the goal was to kind of harmonize the treatment of the things, right? Not so much the histology and such, but to put things into treatment categories. And they, of course, appreciate that. But pretty much everyone else is not really feeling it.
LVI is tricky.
Yes, and the other
Enough.
thing, I found that interesting that Dr. Nofag-Moses said that Dr. Matthias Kui said, oh, you can use keratin or stains, and all the studies are done by H&E only, right? So that's an interesting thing that he had said too. So yeah, we find it difficult to quantify LVI. And the cutoff is so low, right? If the cutoff was like 20, let's say, okay, there's a lot of room there, but when it's 3 or 4 or 5,
We
yeah,
deal
it's
with it all the
tricky.
time in tumor board. It's tricky. It's uncomfortable.
Yeah.
Given the, and you got to review them and see if they're properly evaluated, and there'll be disagreements there too.
Yeah.
What else? If
Yeah.
you like, I'll do case 3 and stop. And if people want to delve into the rest of the PowerPoint, they're welcome to it.
Sure, that would be wonderful. Anna, anything before Dr. Crum does his last case? Julian, can you help with this?
I probably wanted to say that I think generally classifications now moving to this different format, and it's the same we see with the prostate, where there is a risk stratification. So this FIGO system is trying to put the risk stratification rather than really classifying the tumors.
I agree with that too. Just whether it'll stop here, as Anna alludes to, or they're going to continue to tweak it as people start responding. Okay, just one last case. This is a case we got several years ago. It's a solitary lung lesion in I think a woman around age 50, if I recall, maybe a little bit younger. Yeah, I think she was in her 40s for sure. And this is the mass. It's a single mass that was seen in consultation. At higher power, you can see on the left side, there's a little bronchial epithelium, and then there's this epithelioid neoplasm on the right. Higher power, you can see that some of the epithelioid cells are encased with fibrin or some fibrin-like material. There's somewhat, maybe a few clear cells in there, clearish cells with some irregular nuclei. Again, here's another just an image of this. We stained it for P63, and you can see the cells are strongly positive for P63. And so our diagnosis was that of a metastatic epithelioid trophoblastic tumor based upon this morphology of the fibrinoid deposition, and there was also GATA3 staining. In general, you would recommend examination of the uterus and adnexa to exclude a primary epithelioid trophoblastic tumor, since this is often where they do metastasize to. The outcome in this case is the uterus and adnexa were actually normal. And so the diagnosis was revised to a primary epithelioid trophoblastic tumor of the lung. Whether they're truly primary is hard to say, but in the review of the literature, there are rare reports of pulmonary ETTs with normal gynecologic tracts. The outcome is uncertain. I'm not sure there's much evidence that it has an adverse outcome. It's just not been very clear. Take-home lesson was, you can request an evaluation of the uterus and adnexa. You always would in a case like this, as clinically appropriate. It may be possible to evaluate it without actually taking it out, but just to make sure there's not an epithelioid trophoblastic tumor there. So I just mentioned that because we didn't think of it until obviously we found nothing. A couple of quick things just for the trainees. There's your typical ETT, which you stain with P63 and with GATA, of course. Your PSTT, or site trophoblastic tumor, is a MELCAM positive tumor, which has a much more, it's less well differentiated, not as epithelioid, sheet-like growth with strong MELCAM positivity, inhibin positivity, and a very elevated MIB1 stain. Then your chorios, of course, are mixed epithelial, mixed trophoblastic population with both syncytial and cytotrophoblasts with hemorrhage and necrosis. Then this is just a case where you have retained villi after a gestation. Usually I tell them, if you find villi, it's very unlikely you're going to find trophoblastic neoplasia, but that's not always the case. In a case like this, there's some retained villi, and then there's this trophoblastic neoplasm next to it. So it's kind of a thing to always remember. And I'm a little less likelihood to tell people just to forget it if you find villi, because if you find villi, you could still have, this choriocarcinoma that came after a retained placenta. Couple final things to remember when you're looking at trophoblast in the uterus. There's molar implantation site, of course, which is more well-spaced nuclei. The MIB index is not that high, and you must think about a hydatidiform mole. In the you have exaggerated implantation site, which I'm not sure is truly exaggerated, but it's a good section with a lot of implantation sites. MELCAM positive, very low MIB, very. And finally, just a little take-home lesson. Pre-villus trophoblast in a very small sample can look like a choriocarcinoma, or it looks very primitive. And I've seen cases like this misclassified as trophoblastic neoplasia. And you've got blood clot with a small fragment of pre-villus trophoblast. You see cytotrophoblast and a hint of syncytial, but you don't see the more aggressive appearance of a choriocarcinoma. So we'll stop. And last one, I'll show you. This is just to go back to our thing about sticks. The stills metastasize. This is just a tubal proliferation we had many years ago, which we called a still, because it had it was a lining of the surface. It had a very low proliferative index. It was fairly well polarized. Had strong P53 staining, almost no evidence of exfoliation. I just happened to look this up about a few months ago, and she developed metastatic carcinoma 18 years later, or excuse me, 10 years later. So with that, I'll stop. So the rest of these are kind of mundane. It's a little thing to remember.
I'll just say one thing, Dr. Crum. I mean, I think I'm certainly speaking for myself, but I think I'm speaking for most people when we say that trophoblastic things, most people don't have a lot of experience with and find extremely difficult.
It's true, and believe me, Dr. Nucci, my colleague, is really a good pathologist. She relies more and more on our trophoblastic on Brad Quady, who's our placental pathologist, and so usually when we see it, we turf it to Brad. The thing I think with trophoblasts is you do get these mixed lesions, or lesions that don't fit, and they're kind of exasperating. Yeah.
So tough.
And they're not as easy as they look in the books.
Anna, anything for Dr. Crum, or I guess your final words?
I really want to thank Dr. Crum for sticking with us for this long day. And I always had an impression it's everything you presented sort of so easy and straightforward. So it tells that there is a lot of work behind it. And thank you for sharing your wisdom. Every take-home message is really important, and you outlined it very nicely with the sense of humor. I really appreciate you being with us. And I'm sure the audience is thrilled to tell you the same thing. So thanks a lot for being with us.
Thank you. We've all learned a lot and we have the scars to prove it.
All right. I also would like to thank Dr. Crum for coming all the way up to Toronto to talk with us. And to Ji-yoon, who did all the organization for the conference, to our sponsors who helped support the conference, and to our admin staff, particularly Sandra and Intu, because they did a lot of work organizing behind the scenes. I hope you all enjoyed it. I think we covered a lot of ground on the gynecologic pathology side, and kind of reminds you that a lot of things are molecular, but a lot of things are still what we're looking at and trying to figure out what we're looking at, because patients may think that pathology is an absolute, but it really is a lot of gray that we're pink and blue that we're trying to resolve into something not so gray. So again, thanks again to everybody who spoke today. Thanks to all the attendees online, because I see we've actually had quite really excellent attendance online. Also, thanks to Anna and the gynae community of interest, because obviously there is a large and very involved community of interest who are online today. And hopefully we'll see you again for a future Roderick Ross meeting.